Hi, my name is Tina, although I'm going to try to see if my husband and kids will now refer to me as Dr. Tina, now that I've been through mini medical school. It can happen. So I'm here today just to give you some information about what we do in estate and gift planning for the UC Davis Health System and UC Davis. And first of all, I just wanted to mention, if you don't already realize, that any gift you give for mini medical school is tax deductible. And actually, I do love to talk about the D word. And this time of year, the D word always means to me deduction, as in charitable tax deductions. I want to make sure that if anyone has an interest in giving, or if they have a passion for a certain area here at the health system or at UC Davis, that we allow them to give in the smartest and best way possible for them. So that's my job as a planned giving person. I work with donors. I help you make the gift in the best way possible for you that saves you taxes. It's fun, and I really enjoy, and I have a passion for supporting the health system and all the good work done here. Now, I'm going to end with apologies to Dr. Hirsch. I was inspired by him, but he may want to disavow knowledge of me after this, and Carl Castle as well. But I have a limerick. I hope you'll help me fill in the last final word. There was a fine fellow named Purvis. He wanted to give, but was nervous. He set up an annuity to give in perpetuity, just not to the Internal Revenue. Great, thanks so much.
Thank you so much, Tina. I'm feeling very nostalgic. It's very exciting. We should also start announcing class reunions. So I think that this year we'd like the classes of 02, 03, and 04 to gather on sort of the right side of the class photos, and sort of, so you can just sort of feel that you own some ownership of this mini medical school, and people can envy you for sticking it out for so many years. So, although this is a celebratory time, you have to pass a final exam to graduate. You all know that, right? All right. So this year, I've decided to make a relatively tough final exam because, we've had so many, we have to maintain our standards in the mini medical school. So again, it's going to be 2/3 of the answers correct, and they're going to be based on last week's lectures. So, are you set? Number 2 pencils out. Okay, I see smiles. You should be nervous. I asked if there was Beethoven's Funeral March to sort of introduce this, but we don't have it. So, if you think that your eyesight you're losing, into things you're a bumpin', not cruising, then go see ophthalmology and avail of technology. In your macula there may be, whoa. You pay attention much better than our medical students. Okay. When your kidneys fail and you can't piss, turn to hemodialysis. Cleansing blood it sure can, though it shortens lifespan, this is tough, from sped up, gotcha. Okay, I'll give you a hint. From sped up row. From sped up atherosclerosis. Okay. Nailed you. No perfect score this week. Need a kidney transplant? Not so tall. Baby kidneys work well, though they're small. As your blood through them flows, they mature. The pair grows. With such parts you won't feel old at. Okay, that was easy. You had to make up for the last one. Every year, 16K kidney transplants. Less than 1/3 who need them, luck grants. If through trauma life's ended, by criteria extended, an old donor increases the... Very good, all right. Nasty cataracts had old Monet. When he painted the sky or a bay, they turned red and part yellow, not so soothing or mellow, 'cause the lens filtered out each blue. Outstanding. Very good. Okay, the last one's toughie. In wet AMD grow many vessels. In the retina, blood leaks and nestles. By injecting Avastin, vision longer is lastin', as with damage the macula. Figure out a rhyme. As with damage the macula. Wrestles. Excellent. Okay. All right. See, it's we got. I think you got 2/3. So I think that all of you get to graduate this year, and I'm glad that I've maintained my reputation as a stringent grader. Now it's my pleasure to welcome Dr. Garrett Wong, Associate Professor of Clinical Medicine and Cardiology. I knew Dr. Wong when he was a resident at UC Davis, and although he didn't choose to go into geriatrics, he chose the next best thing, cardiology. He did his cardiology fellowship at UC Davis, and became interested in invasive cardiology, and went on to do a fellowship at the Scripps Clinic in San Diego, and then was lured back to join the faculty at UC Davis because he's so talented at threading catheters through vessels so stenotic, it's analogous to running a garden hose through a cocktail straw. And ladies, I am told that he can also thread a needle as well as a catheter, although he has to do it under fluoroscopy. So with great pleasure, I'd like to introduce to you Dr. Garrett Wong.
Well, thank you very much, Dr. Hirsch, for inviting me to participate in this course here. This is a privilege to be here. I welcome you all. Again, extend a warm welcome from Dr. Hirsch as well. My mother usually attends this meeting. I see a couple of her friends in the audience here as well. And unfortunately, she's at a funeral today, so she won't be able to be here, but she still has yet to hear me speak, so hopefully I can do her justice and her friends could hopefully give me a good report card. I did not know the theme was to have a limerick here, so my lecture does not rhyme, unfortunately. Not much rhymes with angioplasty, right? I'm using this microphone, right? Okay. So here's my topic today. The topic is to take heart despite a bad heart. Advances in restoring clogged coronary arteries without bypass surgery. So obviously we know bypass surgery has been around for decades. It's been the standard of care. And so up until this point recently, we've been doing a lot more procedures through the catheters in the leg. We put catheters through the little wrist in the artery, catheters through the groin. And so instead of doing the standard open heart surgery, and I'm sure maybe some people here, and certainly have known friends or have had family members who have had open heart surgery, it's a big production, it's a big recovery period of time, rather than going home with a little tiny catheter in the leg or in your wrist. So my objectives today are as this right here. First of all, just briefly review the pathophysiology. I know we have a highly intelligent crowd here, so everybody knows the pathophysiology and the atherosclerosis, as Dr. Hirsch was saying. That was not my limerick, by the way. And talk a brief history about coronary interventions, where we've come from to the little balloon angioplasties to some of the latest and greatest advances in the stent technologies. Discuss some of the new percutaneous options, and also some of the new technologies that we have now to open up vessels that previously were unobtainable, that were not able to be opened. Here's a, oops. In case the first video I'll be showing you is a little slide just showing the natural progression of atherosclerosis, and it shows a cool little video of the plaque gradually growing into the blood vessel. Hopefully it'll come up here in the next minute. We don't have to go to graduation yet.
Tell us what revascularization is.
Revascularization, sure. Well, revascularization is, obviously I wanted to show you these nice pictures of how the plaque progresses in the arteries, and you have a lot of cholesterol built up inside the arteries, and over time, the video is going to show you that you have a nice normal lumen of the blood vessel. And over time, as you start to develop cholesterol and plaque inside the blood vessels, it's interesting that the vessel actually grows to accommodate these plaques. Dr. Glagoff was the first person to discover this, and we thought that the arteries are somewhat similar to a lead pipe, meaning that you get a certain amount of clogging in there and it reaches a certain point where it becomes critical and it occludes the vessel. Well, it's actually not true. It's actually, when you first start to develop your cholesterol, the vessel will actually grow to accommodate this plaque inside the artery. It's not until you get to the very late stages, a lot of cholesterol buildup, that you actually start to compress the lumen here. And so that's what the video is trying to show you here. So revascularization, certainly this is a very intelligent audience, and the mainstay is always preventive medicine. And that's certainly not the scope of today. Everybody knows you should be on an appropriate low-fat diet, regular aerobic exercise. I'm sure everybody's exercising 3 to 5 times a week here, right? Daily aspirin, our dosage of aspirin has changed now. Instead, we used to have everybody on 325 milligrams of aspirin. It turns out that 81 milligrams is probably good for most people now. So we have kind of gotten away from the term baby aspirin. We don't like to have baby aspirin for all of our adults here. So 81 milligrams is probably a reasonable maintenance dose for those people. And then obviously getting your cholesterol down, your blood pressure controlled. Obviously, if you smoke, no more smoking, get off the cigarettes, and so on and so forth. Different things like heart-healthy diets, fish oils, and that such. But revascularization is when you get to that end stage, and unfortunately when the arteries become so blocked that you're not getting enough blood flow, not getting enough oxygen to the heart muscle, that you start to get what we call ischemic. Ischemic is a medical term for decreased blood flow or lack of blood flow to the arteries. And so revascularization, there's 2 different ways you can do that. One is the standard procedure, as I mentioned before, and we'll go over some of the indications for open heart surgery. So typically, there are 3 major blood vessels to the heart. 1 vessel on the right side, called the right coronary artery, and then 2 vessels that come off on the left side. And an incident, we give the analogy that it's like a big tree trunk. We call it the left main coronary artery. It's a left main trunk. It's like a big oak tree. So that big trunk gives supply to the 2 other major vessels, the left anterior descending, which comes across the front of the heart, and the left circumflex, which wraps on the back of the heart. So we talk about either having 1, 2, or 3 vessel coronary disease. Now you could have 1 branch that has multiple blockages, but we still count that 1 vessel disease, 2 vessel disease, or 3 vessel disease. And as we go through my slides here, typically people with 3 vessel disease, or if they have disease of that important left main trunk because it supplies the 2 other major arteries, so about 2/3 of the blood flow comes off that main vessel, those are pretty standard indications for needing open heart surgery. But as I'll show you today, there are some new improvements that we've been making, and in the field of cardiology where we can actually open up some of these blockages and do things that we weren't able to do in the past. Now let's see if we can get this thing working here. Okay, sorry about that. So here's a fancy video. A little stalling there. But this again is what I was showing you here. Again, the artery is not a standard lead pipe as we used to think it is. It's a very mobile organ. There's a lot of contraction and relaxation that occurs with the cholesterol buildup. And as this animation shows you, this lipid and cholesterol buildup in the vessel gradually grows and expands the artery, so the lumen doesn't get compressed until you really get a large volume of atherosclerosis that really starts to compress the lumen there. It's not until you get to severe stages like this that we start to see people having symptoms and having the risk for an artery closing off and causing a heart attack. So there are different ways, different modalities to evaluate. There's obviously stress tests, treadmills, and things of the such. But to actually look at the coronaries, there's really only 2 ways to directly look at the coronary arteries. One's with a CAT scan, and by that I don't mean this CAT scan here. You don't see too much there, but more like this CAT scan here. So here's an actual CAT scan of a patient's heart here. It's pretty amazing. The CAT scan spirals through the heart and stacks up multiple images, and it's actually able to reconstitute these pictures into a 3D model. And you can rotate this in any different direction you want. And you can see here the different arteries as I was talking about here. Here's the aorta coming off for orientation. This is the left main trunk that I was talking about, and it gives rise to the left anterior descending. We like acronyms in cardiology. The LAD, left anterior descending, and the left circumflex, which wraps around or circumscribes the left side of the heart. And then on the right side is a single vessel that comes off the right coronary artery. And again, you can rotate this in different views here. So obviously, this is a nice example of looking at the coronary arteries here. What we do in the cath lab is this. We actually thread little catheters up to the heart. A catheter is a long, hollow tube. We squirt some X-ray dye into the blood vessels. It's usually some sort of iodine-based contrast that we use. And then we take X-ray movie pictures of the heart vessels, called an angiogram. An angiogram is basically just a picture of any blood vessel. Coronary angiogram, of course, is pictures of the heart vessels. So here's an example. Again, the left main coronary artery, left anterior descending, left circumflex. So we're taking pictures. The dye shows up as black on their X-ray TV screens there. So this still remains the gold standard. And in honor of the Sochi Olympics here, here's a gold medal here. This happens to be for the biathlon. But coronary disease, it's obviously a very prevalent disease. Unfortunately, it still remains the #1 killer for both men and women. That's why there's the whole red dress campaign, just to get the public awareness out there for women as well. The #1 cause for women to pass away, unfortunately, is still cardiovascular disease as well. This is an older slide, about a decade old, but the numbers have just only grown here to over 100 million annual visits a year for coming into the hospital, and about 8 million of those come in for having chest pain. Now, all the chest pain is not related to the heart. There are different things like blood clots and so on and so forth. But still, roughly 2 million people come in with a variety of different things. I'm not going to go through each of these here, but coming in from a heart attack or something with the artery that caused the artery to close off. Typically, the first thing we'll do is get an electrocardiogram. I'm sure there's some people who are used to looking at EKGs here, but this is a person who unfortunately has a massive anterior ST elevation myocardial infarction. It's a lot of words there, but basically it means that the front vessel of that heart, the most important of the 3 vessels, is completely occluded with the blood clot that closed off there. So a couple things we do, we always get blood tests, and if the heart has been damaged at all, the heart cells start to die, or necrosis we call that, and they release their contents into the bloodstream, and we can measure those with these different blood tests right here. You can draw different cardiac markers called troponin or CK or creatinine kinase, and those tell us how much and what degree of damage has been in the bloodstream. So if someone's told you you've had a heart attack, we'll get blood tests to confirm that there has truly, in fact, been some damage to the heart, in addition to looking at the EKG portion of the heart as well. So what happens in an acute myocardial infarction? Again, this is definitely time-lapse photography. This does not happen in real time, fortunately. But again, you see the cholesterol right here starting to build up and start to compress the lumen. And even when the lumen is not completely occluded here, as I showed you in that first video, what happens is you get this cholesterol buildup, you get this so-called thin fibrous cap, and typically right at the edges of this where the cap is the thinnest, you get this so-called plaque rupture. That's a catchphrase that we use in cardiology. You hear all the cardiologists say, oh, you probably had a plaque rupture. This plaque here cracked open, whether it's from physical stress, emotional stress, something like that that caused some damage to the heart to crack open there. It exposes all the chemicals inside the blood vessel here that leads to a whole cascade of clotting events. It leads to being partially occluded like this. If you guesstimated maybe 60, 70% occluded, to form this huge clot there to completely close off the artery. So in an instant, you can have a heart attack like that. So it's very important, all the medical management, which I'm really not going to go into today, but aspirin, blood pressure control, lipid-lowering therapies like statins, and so on and so forth. So this is obviously what we're trying to prevent with the procedures, as the gentleman was asking about revascularization. Here's a couple of bad outcomes. Anytime you see a pathological specimen, obviously it didn't turn out too well, right? So here's an example of the top one I showed you. This is a cross-section. Looks like a little egg roll there, huh? A cross-section of a blood vessel. Here's a little plaque here. And what happens when it ruptured, it leads to the whole cascade of events, and you completely occluded and clotted off that vessel. So there's blood clot in there that closes off the vessel completely, similar to that EKG I showed you. You would get the ST elevation myocardial infarction. It doesn't have to completely occlude the vessel, and you can see right here, here's the big lumen here. It ruptured open this plaque here. Now, normally this would all be filled with cholesterol and lipid inside here, and when it cracks open, it spills out all the contents into the blood vessel, and the blood clot kind of goes into that lumen, as well as partially occluding the blood vessel here. So even a partial occlusion can cause a heart attack, which could be life-threatening. So these are obviously the outcomes we're trying to prevent. What's going on inside? Again, just a little cross-section to show you what's going on here. This is a sideways view of the blood vessel now. And again, this was that plaque I was showing you earlier here, kind of a sideways view. And again, when it gets cracks open and gets exposed, it leads to a whole clotting to either partially occlude or completely occlude the vessel. And either of these can lead to what we call sudden cardiac death, which is typically an arrhythmia. It's not due to the blocked artery. You don't get enough blood flow to the heart, it gets very irritable and can lead to a life-threatening arrhythmia, which is why we have defibrillators on airplanes now, casinos, major hotels, all have defibrillators to prevent sudden cardiac death. So the goals are obviously to block partial occlusion to degenerating to full occlusion, and either of these to lead to sudden death. That's our aim in cardiology, certainly. Here's what it would look like what we take someone to the cath lab. Again, we snaked a little catheter up to the heart. We squirt the X-ray dye in there. This is an example of the right coronary, which comes off by itself here. And see how you have this filling defect? It should be a nice smooth tube here. That little haziness there, or lack of blood flow or lack of contrast going there, that's a big clot. So that, again, that plaque had ruptured and a big clot had formed and partially occluded the vessel to giving the person the heart attack there. This incidentally is a pacemaker. The right coronary typically supplies the pacemaker system of the heart, and if you have a blocked artery to the right coronary artery, they could come in with heart block, and they have no pulse from that as well. There's a little blood clot there. So what do we do now? So that's the whole field. Before interventional cardiology, really the mainstay was aspirin, maybe some medications like a beta blocker, having them sit in a dark corner, and you just let the infarct evolve. You watch the person literally have an infarct. And the goal was to keep them calm, get the blood pressure nice and low, and have them relax in a dark room for about a week. And now we have medications to slow down the heart and do these kinds of things, and the goal now is to get in there and actually open up the artery. But it wasn't until the 1970s where this whole field of interventional cardiology really came about. Andreas Grenzig, a famous German cardiologist who unfortunately died in a plane crash, was the first person to develop this human angioplasty. You guys heard of angioplasty? Just basically take a balloon into the artery and expand it open to compress the plaque open there. So he did his first presentations, and the first things were obviously in animal studies, but his first human trials were done in the late 70s with his colleagues at UCSF, where they actually did it during open heart surgery. So the patients had the artery open in surgery. They were able to slip the catheters through there and do the balloon right at the time of surgery. So the patients were going to bypass surgery anyway. It wasn't too long from there that they did a completely percutaneous procedure. Percutaneous is a fancy word that basically means we go through the skin. You can either go through the arm or through the groin and snake these catheters directly through the skin into the heart. So the first recorded angioplasty, what we call PTCA, percutaneous transluminal coronary angioplasty, was done in 1977. Here's the first patient here. He's obviously famous, and obviously he gives credit to doing his name and pictures in all of these talks here. Still alive, doing well. So in 1977, this new field of interventional cardiology was really born. So interventional is similar to what I do. We go in there and intervene on the arteries here. The first thing we do, as Dr. Hirsch was mentioning, we snake a little tiny wire, 14 1,000ths of an inch wire, through the catheter all the way up into the heart and able to twist it down into whichever artery we want. We put a little bend on there, and we can really steer it to whichever vessel we want. Then we basically, as you saw the animation there, pass a little balloon over that wire, and the balloon just acts, the wire acts as a rail. So you could push the balloon, and it will find its way into these really twisted or tortuous vessels. And you stretch open the wall. So it's controlled stretching and cracking open of these plaques. Again, I showed you the cross-sections earlier just to help understand the process and why we've come from where we are now, where we came from. Here's a cross-section of the artery. The yellow is like the cholesterol, the plaque buildup in the artery. And after angioplasty, the acronym now is kind of funny. We call it POBA, plain old balloon angioplasty. It really is. We don't call it PTC anymore. Everybody calls it, oh, we just POBA'd that. So it's POBA. But nowadays, it's either angioplasty or typically, I'd say 90–95% of the time, we'll stent it and put a stent in there after the angioplasty. But as such, in the 70s, the problem is when you stretch out these vessels right here, you get immediate elastic recoil. The vessels have elastic tissue just like your skin, and you stretch them out, they would shrink back down to a certain percentage right at the time, and then later they'd shrink down even more. As such, sometimes half the percent of the people would come back for repeat restenosis. Restenosis, again, is this new catchphrase as well, where the artery starts to shrink back down again. Also, now that we've actually stretched out the vessel and we've caused some pressure changes to the vessel, something called barotrauma, that it sets up this new pathophysiology, which we never even heard of before. And you stretch it out, and then the trauma alone to the vessel leads to this new production. This blue layer here now is what we call intimal hyperplasia, or neo-intimal hyperplasia. The hyperplasia is this increased growth of tissue. What we tell patients is basically scar tissue that's forming inside your vessel, which gets set up by stretching out that vessel. So prior to angioplasty, we never heard of this. We just had atherosclerosis. So it wasn't until 17 years later that they found out ways to get rid of that elastic recoil. Well, what if we put something in the artery to prevent the vessel from shrinking back down again? And you put a piece of metal in there, and the very first one was just like this. It was a tube that they laser cut these slots in there. And then when you stretch open the vessel, almost like chicken wire, it opens up to these little diamond-shaped cells there. These are the two inventions of the very first stent, Dr. Julio Palmaz, and one of my previous mentors down in San Diego, I had the privilege of working under him, Richard Schatz. So the very first stent was called the Palmaz-Schatz stent, came out in the early 90s. And you'll see the little picture down here. After you do the balloon angioplasty, it takes a little while to laser cut these stents here. Believe me, he's told me many stories about the very first time they're putting these in the arteries. People are like, you want to do what? Put this in my artery? No way. So it was unheard of initially. And you'll see down here now the same wire that we had into the vessel, we have a balloon that's the stent is actually crimped down onto the balloon. You inflate the balloon, and it stretches and expands that stent into place. You deflate the balloon and take it out, and all that's left behind is the metal tube there. Acts as a little scaffold. So we call it the stent there. So now you don't get that elastic recoil. The angiographic pictures look beautiful. If you had any injury, sometimes the balloons alone can tear the vessel, what we call a dissection. So this really stabilized the plaques and made it much, much more easier to do. So it's actually become much, much easier to do angioplasty now than in previous generation. So going back to the schematic here, what does the stent do now? Now, here again, here's your initial vessel. After angioplasty, now you have those little hash marks here. That's a cross-section of your stent. You don't get that immediate elastic recoil, but now having this piece of metal there that's there forever, the initial ones were surgical stainless steel, having that metal there sets them up for restenosis. It's very inflammatory, it's a foreign object, and the body tries to heal over that, and you actually get more scar tissue development. But you've eliminated that initial elastic recoil, and now the scar tissue was decreased down to 25% of the time. So you could tell your patients consistently, 1 out of 4 of you might need to come back to be retreated for that built-up scar tissue inside that stent. Okay? So again, this new catchphrase, now, in-stent restenosis. So you may hear your doctor say, no, you have ISR. ISR is in-stent restenosis, that scar tissue. So what can we do about that? Well, previously you tried to balloon that out and balloon it open. The problem is when you balloon open that scar tissue, again, very poor outcomes. Once you are set up for this pathophysiology of developing scar tissue, it came back again. You can see here that prior to different treatments, maybe 50 to 70% of the time they had to come back in for more recurrent restenosis. Brachytherapy was a therapy that we had that's come and gone. It's no longer FDA approved after the latest generation of stents here. You can see here, again, this is a cross-sectional specimen. You see the little hash marks here. That's a stent. And you see all that tissue inside there. That's scar tissue. That's the restenosis tissue. On a stain under a fancy microscope here, you can see the hash marks here. That's your stent. This is all the scar tissue that's grown inside there. Again, if it's mild growth, that's okay. If it becomes occlusive again, they need to be retreated, again, to limit their symptoms and reduce the risk of a heart attack. So brachytherapy was something that came and went. We had got this technology. A lot of our radiation oncologists use radiation to treat significant scars and keloids. So we borrowed that same technology and transmitted it to the coronaries to eliminate the restenosis. And you actually can cut the restenosis down in half with radiation therapy. But it really wasn't until the era of what we now call DES. We think the third big landmark change in stent technology is the drug-eluting stents, or what we call DES. So the previous stents were BMS, bare metal stents, and now the current era is called DES, or drug-eluting stents. And this came out about a decade ago, and now we're literally on the third generation of drug-eluting stents. And what this does is the drug coating is designed to eliminate or certainly decrease that scar tissue. Again, we borrowed this from some of our hematology and oncology colleagues, as well as the transplant surgeons here. As some of you may know, Taxol is certainly a drug that's been used for breast cancer. It prevents the separation of the cells, or the mitosis of the cells. And then rapamycin or sirolimus, and there's several different generations of what we call limus drugs now, similar to sirolimus, that are designed to help prevent tissue growth. So this is initial drug was used to prevent kidney transplant. So these are the very first 2 drugs that were developed. And you think, oh, great, just dip the stent in there and put it in the body. Unfortunately, it's not that simple. And the problem is you need to slowly release. They've done experiments trying to quickly release a drug, intermediate release, or long-term release of the drug. Which one's better, and when do you really need to block that scar tissue from developing? Turns out it has to be somewhat intermediate. So within the first 3 to 6 months, you want that stent to be able to deliver the drug. So you had to come up with these fancy polymers. You have to put some little fancy coating onto the drug. A polymer is just these different type of biocompatible coatings they put on the drug, and they embed that in there, and they could slowly release the drug into the body over the next 3 months, 6 months, 12 months, really whatever they want to design. And it has to be vascular compatible. The problem is just the coatings alone were inflammatory and were setting people up for more scar tissue. So it became very tricky. So you'd think it'd be very simple, but literally they tested hundreds of compounds and many, many different coatings to find the right combo. And 2003 was when the first drug-eluting stents were about. So this is our current era right now. This is what we're doing now. So what kind of lesions can we do now? For here, an example, again, is a picture of a coronary anatomy. And here's that left main trunk, as I was talking about before, which supplies the other 2 major vessels, the left anterior descending and the left circumflex. These aren't on the test, by the way. So if you could zoom in here, it's hard to see this, but if you zoom in right here and right here, Ostial is where, like, the origin of the vessel. Right where the origin comes off, you see that big, how it's kind of lighter there? That's a big plaque there. It should be a nice dark tube, completely filling with contrast. Unfortunately, it's a sliver of blood flow going into this left main vessel. And you can see it over here, almost like a bird beak, right where it comes off. So it's about 90% closed off there. That closed off 100%. 2/3 of the heart's not getting blood flow. These are typically the people that don't make it to the hospital. They have sudden cardiac death. So we saw this. We didn't let this patient leave the hospital. So typically, again, that left main trunk is so significant that the current guidelines say that person with left main disease, when you hear them say left main disease, we mean disease of this vessel right here, should go to open heart surgery. So that begs the question now, again, as I alluded to before, which patients should go to PCI, again, another acronym we like to use, percutaneous coronary intervention. So that's what we do, the angioplasty, stenting, and so on. That all falls under that umbrella of PCI, or CABG. Have you guys heard that term, CABG? So that stands for coronary artery bypass grafting. Again, patients are finding, what are you talking about, CABG? So PCI or CABG. So that's the main differential when you see critical disease like this. And here's the typical PCI or angioplasty patient, someone who has one vessel disease or two vessel disease. Those do quite well, the complications are low, and those are patients that will, standard of care is to do angioplasty for those. Now here's the list of people that typically get referred for open heart surgery. So left main disease, like the picture I just showed you. Someone who has multi-vessel disease, that blockages in all three of their major vessels. If they have chronic total occlusion, what that means, we call that CTO, or chronic total occlusions. That's one of my areas that I focus on, is when a blockage artery is closed off so long that's been closed off for a minimum of 3 months is a definition. Okay? So that's a CTO. Severe LV dysfunction, LV is the left ventricle. If you have severe weakening of the heart muscle due to repetitive injury from the heart, then that's someone who may go to surgery. And obviously, if they have a valve lesion as well that you can concomitantly repair at open heart surgery, that may be a person that's in a surgery as well. Although I know Dr. Rogers, if some of you here were last year, he talked about some of the techniques and procedures we're doing to replace valves as well without open heart surgery through catheters. And we've done about 90 of those at UC Davis. So I know it's early in the morning. I didn't want to have too many gory pictures here, so I spared you from most of them. This is basically an open heart procedure here, and you can see all the tubes and wires and everything going into the heart. You literally have to stop the heart, put on a heart-lung bypass machine. That's what they mean to go on bypass. You're circulating, you're acting as a heart, acting as a lung for the patient while they're doing their open heart procedure. Big procedure, long recovery period of time. This is what they're doing, our surgeons here. You have a blocked artery here. Again, here's your schematic of the heart. If you have a blocked artery right here, so instead of trying to actually open up that blockage, you simply bypass it. So you take a little tube off the aorta, pass it down beyond the blockage, and sew it onto there. And you could take these conduits. The blue one here is a piece of vein. You take from the vein, from the leg. It's called a saphenous venous graft. And this is one that comes off right off the arm. The blood vessel goes out to the arm called the IMA, or the internal mammary artery, and that supplies the chest wall. So you take that one, dissect it away from the wall, and plug it right on top of the heart. So there are different conduits or tubes that we can use to bypass the blockages. So what we do in interventional cardiology is a little bit different. We don't go around the blockage. We actually try to open up the blockage. I had this funny cartoon. I should have put it in here. It shows the difference in plumbing. The plumber would go there and actually unclog the drain, when they have the surgeon would actually put little pipes there, come to your bathroom, and add a new pipe to pass the blockage. Didn't want to be that mean to our surgeons. Surgeons do great work. But it's a very different procedure, and nowadays we're doing a good proportion, probably a third of our catheter procedures we're doing now through the wrist. So you can snake, we have better catheters and wires and techniques that we could actually get up into the arteries directly through a small artery wrist. End of the procedure, you take it out, you put a little wristband on there, you can sit up, you can eat, all that kind of good stuff that you couldn't do before. So the answer is not so clear anymore, and hopefully by the end of my talk I'll lead you with some insightful things that maybe we can do more with what we're doing in the cath lab rather than requiring open heart surgery. So talking about severe left main disease, I didn't want to get too heavy on the data. I just wanted to show you a couple big landmark trials that have come out and starting to change our practice now. One of them is called the Syntex trial. This is a large international study here where they took 1,800 patients, and the 1,800 patients had significant disease, and they had to be evaluated both by a cardiac surgical team and a cardiology team. So both of them had to decide, okay, this person truly has severe left main disease, or they have severe three-vessel disease. They could be a good candidate for surgery. The cardiologist looks at it and says, well, it's severe, but I think we can get a good result as well. And so those are the patients that got randomized. And you can see here, 1,000 people had the three-vessel disease arm, 700 people were in the left main arm. Okay? So that's the people that got randomized. So it's a blinded fashion. You don't know ahead of time what the patient's going to get. You tell the patient, well, if you have severe disease, you can either end up 50-50 chance of needing getting surgery or multivessel angioplasty and stenting. So this has been done now. They have 5 years of follow-up. It's been presented every year at our national meeting. Now we, as of last year, got the full 5-year data follow-up for that. And what you see here is on the y-axis here is the cumulative events. And this is, we again use a lot of acronyms. This is major adverse cardiovascular and cerebral vascular events. So it typically encompasses death, obviously, it's very important. Heart attack, stroke, or the need for repeat revascularization, meaning if they have scar tissue, they have to come back for repeat stenting. And you can see here, for all the statisticians out there, you need to have a p-value of less than 0.05 to be statistically significant. So it did not achieve that. So the yellow line, although it's a little bit higher, that's your stenting arm, had a slightly higher events. There's no statistical difference between that and surgery. So up to 5 years for left main disease really was no difference. They broke that down. There's something called the Syntax score, and I certainly don't want to bore you with that, but it's something that we do when we look at the coronary films. We actually go through and categorize each of the lesions in terms of complexity. There's very simple cases. It take 10 minutes to put a stent in. Other ones, you're in there. We use drills and lasers and whatnot to open up some of these blockages to treat that, and you could be in there for hours. So the complexity is the so-called Syntax score. And what we found are for the subset of the low and intermediate scores, so the ones that we think as interventionalists are pretty straightforward, they actually had no difference at all. The p-value was essentially superimposable at 5 years between PCI and bypass surgery for the relatively simple lesions. In fact, if you looked at all the subsets here, I'm not going to go through all the data on here, there's actually a statistical trend toward being favorable with less mortality with angioplasty and stenting rather than open heart surgery. Surgery is a great procedure, but again, you have the surgical comorbidities associated with that. Unfortunately, if you look at the higher scores, so there are some patients here with a Syntax score that's high, so the upper tertile, they broke it up into low, intermediate, and high risk complexity. So the higher complexity lesions did better with surgery, and you can see the yellow here. There's no overlap at all. So people who are high risk and have complex lesions should still undergo bypass surgery. So I don't want you to leave here thinking we should and could do angioplasty on everybody. But when you looked at the data from this particular trial, approximately 1/3 of people significantly would have done just as well or perhaps better with angioplasty alone and not had to undergo bypass surgery. And again, this is an older trial. At least up to 5 years, we have equal or perhaps better data compared to our surgical colleagues. Well, what about the multivessel disease? These are people who have significant blockages in all 3 major heart vessels. And again, we typically say if you need to have multiple blockages, the surgeons could get what we call complete revascularization. And again, the Syntax trial had that subset that I showed you as well. I'll show you that arm here. And again, now it turns out that only really the low-risk scores, the low-risk Syntax scores, so the relatively straightforward lesions. You can have 3-vessel disease. We are very focal blockages in all 3 vessels, and we could be in and out of that cath lab with all 3 stents in less than an hour, or there could be really complex ones. We may not even attempt everything. We may fix one blockage and bring them back in a few weeks to fix up everything else. So again, it's a huge spectrum of disease that we see there. But for the low-risk scores, again, the lines are essentially non-significant. So low-risk score patients can do well up to 5 years, again, based on this trial. And we've actually adopted this. The guidelines have changed to say that based on these lower complexity lesions, it is a viable option to undergo multivessel stenting rather than rather than bypass surgery. Here's an ongoing trial right now. That other trial was with the first-generation drug-eluting stents, which I'll talk to about in a second here, and didn't have the current technologies that we're using now. There's an ongoing trial. We're part of this at UC Davis, which is more current era. It uses the latest and greatest drug-eluting stents that we have. It standardizes the procedure. In the previous trial I showed you, the cardiologists can really do whatever they want to get the best result they thought. Although some techniques are better than others and so on and so forth. So this current trial here makes everybody get the same exact type of result, same exact technique, and they all get the latest and greatest third-generation drug-eluting stent on the market, which is the Xience Prime. Okay, so this is ongoing right now. We'll get the results very shortly. They're almost through with enrollment. It's a US trial as well as a European trial. Again, a very large trial, 2,600 people being randomized. So hopefully when this comes out, we may even have broader indications to do our angioplasty and stenting. Well, what about these chronic total occlusions? Again, what exactly is a CTO? By definition, it's an occlusion that's been there for longer than 3 months. You say, well, how can you live with a blockage for 3 months? Well, what happens when the artery slowly closes off over time, the body's able to adapt and help protect itself. I give the analogy, like let's say you just put a big river down, although there's no water running right now, right? If you put a big river down in the bed, the water forms little streams around that and gets down to the riverbed below. That's exactly what the heart's able to do, and you get what are called collaterals. The body's able to have, if you have a blockage slowly close off over time, the other vessels, for example, if it's the right coronary that's occluded, the left vessel will gradually form these little tiny branches over to that area. It's called angiogenesis. So you form these little tiny new branches and actually fills the vessel backwards. So if we see these collaterals forming backwards, we can say, okay, this has been closed for at least 3 months. Sometimes it can be closed for years. And prior to that, if we saw a CTO or chronic total occlusion in a patient, we'd say, you know what, we can't open that with angioplasty. We could fix the other blockage, but you really need surgery. And that was a big cut point to send people to surgery as well. We have a lot of new techniques and technologies to potentially open up some of these. So here's another example. Here's a catheter again coming up through the leg. We're shooting the X-ray dye. This is the left anterior descending coronary artery right here. Here's the left circumflex. This particular, see how the vessel stops right there? No flow going down here. It's kind of a little trickle of vessels going around there. The majority of the blood flow is going to come from the right side to fill in this area right here. So really, CTOs have become the final frontier. Angioplasty has become, as I mentioned, relatively routine, relatively straightforward. We can get very good results for the majority of lesions, but these CTOs are still the final frontier, and these are typically always the mainstay into the arena of the surgeons. They're the most challenging to do. They can be very time intensive. They can be longer procedures. You use a lot more X-ray dye. The contrast we use is iodine-based. And anybody with underlying kidney disease, as you're talking about the transplanted kidneys, the X-ray dye can be toxic to the kidneys. Uses more radiation. Everything we do is based on X-ray. We're using radiation. We wear these lead gowns so we don't absorb too much of that. We're in there every day doing procedures. And prior to that, success rates were in the neighborhood of 50%. But I'll show you some of the new technologies and catheters and equipment we have. We're in the upwards of 80 to 90% for some of these blockages. What's the rationale for opening these? People say, well, it's already closed. It's 100%. You don't get 110% closed, right? But actually, there are some people, and again, not everybody shows the same improvement, but if you have a significant blockage that supplies a large area, if you open up that area, you can improve quite a bit of their symptoms. You can reduce their ischemic burden. Again, that's a medical term for decreased blood flow. They could help improve the heart function. You're not getting enough blood flow to the heart. It kind of puts itself into a quiet state, what we call hibernating. And the heart kind of slows down its contraction, try to rest itself to minimize damage. You reestablish blood flow. Typically, it was with open heart surgery, but now if you could open up blood flow with a stent, the heart starts to contract better again, and they get the function back. So they feel better, survival potentially can be improved, they have less irritability or arrhythmias of the heart, and potentially get off a lot of these medications. Now, all CTOs or chronic blockages are not the same. I'm certainly not going to go through the different indicators here, but we'll look at a vessel, and some look very favorable, very simple, and other ones look very complex depending on the length of the occlusion. Does it involve branch points? Is it calcified? And so on and so forth. So I'm certainly not going to go through that, but we'll evaluate the angiograms very closely before we decide to try to open up something there. Again, the mainstay of what we do in interventional cardiology is all based on the guide wires. And these have come a long way. These are just some of the standard wires we use. They have fancy different coatings. Again, they're all 14 1,000ths of an inch. They're very, very tiny vessels that we could put a curve on the tip. We basically can steer it and advance in and out. You'll be able to get down to any vessel you want. So these ones, the pilot wire has this hydrophilic or very lubricious coating to get through some of these highly stenotic lesions, and so on and so forth. Well, if you can get a wire through the blockage, pretty much we can get a balloon and a stent to follow that. There's all different kinds of catheters we can use to get through the blockage. So the hardest part is getting your wire into the vessel, the true vessel, beyond the blockage. That's the hard part. So there's a lot more newer wires now. The Japanese have really, really pioneered the technology in this. In Japan, just culturally, they're quite against bypass surgery and any type of open surgery, and deforming the body is really against their cultural beliefs. So that's probably some of the lowest bypass surgical percentages in the world are in Japan. So they've really pushed the limits on what we can do with angioplasty and stenting. So pretty much all the catheters, the wires, the techniques have really been pioneered by the Japanese. These are a couple of different wires here. Again, they have different types of tips. This one's even tapered. It goes down to 9 1,000ths of an inch to the tip. These are very little, tiny little needles, in fact, to get through these blockages. Whole series of support catheters to give you some pushability and the support you need to steer these wires. This little catheter called the gopher actually has little screws on it. You can get into the plaque. You can actually literally burrow through the blockage with these little screws type device. And so up until now, though, it was really just trying to get your wires into the blockage down there. And oftentimes with these blockages that are occluded for so long, it's calcified, the wire will deflect all the calcium and keep going outside the artery. And you can imagine using stiffer and stiffer wires, you end up poking holes inside the artery, which is not good. Goes without saying, right? So I put this little caption here. The definition of insanity is doing the same thing over and over and expecting, it's supposed to be a different result, right? Expecting the same result. You go in there, the same wires, same catheters, get the same result. Occasionally you get lucky, and that's why 50% of the time you can get through these blockages. So I'd like to introduce some of the newer technologies now, and we've been using actually all 4 of these at UC Davis here. I'll go through each of these in a little bit more detail here to help us get through these. This first one is called the front runner, and it's basically like a little bioptome, a little Pac-Man. And you basically squeeze the end of it, and it really chomps kind of through the plaque there, and it burrows through. And it depends on the different consistencies of the vessel. The fibrous plaque here, which is a blockage in the actual true vessel, is very hard. So this is able to burrow through that, whereas the vessel wall itself has this adventitial, which is very elastic, and the device would actually deflect off of that. And so it's harder to go outside the vessel and create a perforation with a blunt device compared to a sharp needle with the wire that we were using before. It's got some disadvantages as well, but it's a good device in its time. Now we've kind of come along since that. We have something called the crosser, which is by a company, Flowcardia, and this basically has high-frequency vibration, so 20,000 cycles per second to literally burrow through. And it's pretty cool. In the example, you get a piece of chalk and put this catheter on there, it'll literally burrow right through the chalk. Because it's hard calcium, it'll kind of burrow through the blockage there. If you put it on a piece of thin elastic membrane or silicone, you burrow as hard as you want, you can't rupture. So again, going off the differential properties of the calcified plaque versus the elastic artery. We use laser, or excimer laser coronary atherectomy, not like my little green laser I'm using here today, but more like this here. Here's a catheter. It looks like the little Zamboni that they wheeled out there in the ice hockey rink. So they literally wheel in the Zamboni thing here. It's this big machine that creates, it's invisible light. It's in the ultraviolet nanofrequency range. You can't see it. You have to wear these special goggles so we don't get the light in our eyes. And it's got multiple optic fibers here. And again, this can actually literally burrow through these calcified fibrotic lesions there. The problem is with this one, you have to have the wire first. So this is if you get a wire through, but it's so calcified, you can't pass your equipment. You can laser a little track through there, and then get the balloon, then get your stent in there. So this is really for once you get the vessel wired, how do you open it? One of the biggest breakthroughs is this catheter here. It's called the Crossboss. We helped actually do the clinical trials to get this device approved. It's now commercially available by Boston Scientific. And it looks very simple. When I heard about this, I'm like, what the heck, how's this gonna work? It's basically a hollow catheter with this rounded beaded tip here. It's 1 millimeter. 1 millimeter, it's almost like a little round bowling ball. And you get your wire up, you get to the blockage, and you basically spin this as fast as you can in both directions. And surprisingly, a good majority of the time, it can burrow its way through. Again, with the round little bowling ball on the tip, it bounces off the elastic tissue and won't go through the wall. Or if it does enter the wall, it kind of travels alongside the vessel. Rather than creating a big hole at the side, it travels alongside the vessel, inside the vessel wall. Now, you don't want to be inside the vessel wall, right? You want to be in the lumen. So it comes packaged with this, and this is really what the balloon that changed a lot of what we do now, what we did not think was even possible trying to open up. It's called a stingray. And a stingray, you can imagine, is flat wings with the kind of round body. So that's how it got its name here. You can see the balloon tip right here. It's a very small 1 millimeter balloon in width, 3 millimeter wingspan. So it's got flat wings here, and it's got the rounded body here, which is where the wire travels over that. So imagine you get the crossboss. You pass down, you're into the vessel wall. You want to be able to get the wire back in. Before, we kind of just put a big hook on the wire and hope it gets in there, but it would ultimately just keep traveling along the vessel wall here, as you can see, and continue to propagate that, what we call a dissection. I mean, you're splitting the vessel wall. We really want to get back into the vessel beyond the blockage here. So what this balloon does, when you inflate it with those wings, it self-orients itself around the vessel. You have your big vessel here, those wings wrap around it, okay? And it has 2 holes in this balloon here. They're 180 degrees opposed from each other. So you can imagine one vessel pokes right into the vessel, the other hole pokes outside the artery. So you basically can set up the balloon in such a way on x-ray you can tell exactly where the vessel is supposed to be right here. We can poke the artery, we poke it into the vessel, just like this picture shows right here, beyond the blockage. If it goes out the other way, you just pull it back, turn it 180 degrees, and pop it in beyond the blockage. Then you basically pass a wire through that blockage, pull the balloon out, balloon and stent this thing open, and you create a continuous channel from the beginning of the vessel through around the blockage there. So pretty amazing. So this technology has really changed a lot of what we thought we couldn't do before. So I'll show you a couple examples of these. I put the little schematic here just to orient you with what we're looking at here. Again, the aorta comes off here. So we go backwards, actually, up the aorta, right, with our catheters into where the coronaries come off, the left coronary and the right coronary. The couple examples I'm showing you today are right coronary artery blockages. So the blockage is going to be right about here. So it should be a huge vessel coming down here. It stops right here. And again, as I mentioned, what happens over time, the vessels on the other side, the left vessel right here, is going to slowly grow some branches, what we call collaterals, to the so-called riverbed down beyond the blockage. I'll get rid of that little picture here. So here's what it looks like here. Again, you take a picture, all you see is a little stub there. You have no idea where the vessel goes. Do you push a wire? Is it going to go this way? Is it going to go this way? You don't really know. You don't want to shoot blindly. So what we do now, we put two catheters in. So CTOs do require 2 holes in the artery, 2 holes in the leg. You put 1 tube in the right artery, 1 tube in the left. And you can see this vessel on the left side. See how it fills in backwards? The whole vessel down here is filling backwards all the way to about here. Can you appreciate that? I'll let it play one more time there. This is what we call left to right collaterals. You can get right to left collaterals and so on and so forth. We actually realize that the occlusion is actually only this sort of short little segment right here. So it gives us a target where to aim our equipment at. So this was a case of that crossboss, and again, you get the crossboss right up to the occlusion. You spin this as fast as you can both ways, and literally this took about 30 seconds. Pop right through the occlusion, went to the true vessel here. You pass the wire through there. You get the wire down to the vessel beyond it. You just want to make sure you're in the right spot, right? Make sure you're not into the vessel wall. You can tell. But just to confirm that, you take a picture from the left side, and it goes backwards, and you can clearly see you're in the vessel beyond the occlusion. Now it becomes relatively straightforward angioplasty. We pass a series of balloons. The balloons are all filled with this X-ray dye. The balloons come in different diameters, different lengths, whatever size we need to fill the artery. And it has these little dots here, these radiopaque markers, so we can see in our X-ray exactly where to put these balloons. So you do a series of angioplasty and expand open the vessel. We put a big stent in there. The stents, again, as we showed you in that video before, are mounted on the balloon. You inflate the balloon, it expands the stent in place, deflate the balloon and take it out, and the stent acts as a scaffold to keep the vessel open. So after you do that, you take high-pressure balloons to make sure you fully expand that stent. And here's what the final result looks like now. So again, if I showed you that very first picture, you just had the little stub of where the vessel came off right here. And again, before some of these new techniques, no question, this person would have had to undergo bypass surgery. So now he went home with 2 little holes in the leg. Our holes are about 2 millimeters in both groins. Went home the next day. So we've come a long way now. We've come a long way. What about these so-called retrograde techniques? Well, some procedures you look at, you can't possibly. It's been like similar to that picture I just showed you. Here's an example of a chronic occlusion right where it comes off again. This one, unfortunately, doesn't have a good track that fills backwards, and the majority of the collaterals come from the left side to the right side. But this is a much, much longer occlusion here. So this would not be favorable to try that crossboss technique. And you do a technique called the retrograde technique. Again, this was all developed by the Japanese, in which case it sounds, when I first heard this, I thought it was crazy. You actually go through the left coronary, backwards through the vessel, and pass your wire from this side backwards up that way and make a connection. And there's all types of techniques. I don't want to go into too much of different techniques. You talk about these cart techniques where you're going antegrade or forward, retrograde backward, and you get the 2 wires that connect. And again, all you're trying to do is connect the beginning of the vessel to the end of the vessel when you have the true vessel on both ends, and you fill the rest in with your stents. A couple examples, as I was mentioning before, how's the body able to do that? There's various types of these so-called collaterals. These are when your body grows these little blood vessels, or the angiogenesis to make these vessels help protect itself, basically creates its own bypass surgery. I'm going to show you an example of this one right here. This is similar to the case I just showed you. So in this particular case, the right coronary would come off here, right? It's completely occluded, so what does the body do? The left vessel here forms these little streams, these little squiggly lines are the collateral vessels that filled the right vessel, and now this whole vessel fills in backwards. So this is an example of a case I'm going to show you now. We weren't able to do this with the current techniques as well, and again, the Japanese pioneered this special catheter called the Corsair, and our balloon catheters here are they're pretty flexible, but they're still plastic tubes and very stiff at the tip. To make these tight bends, you just couldn't do that. So this catheter here is very slippery, can make unbelievable bends. It can bend more than 90 degrees on itself and pass along these vessels. So this is essential for these so-called retrograde techniques. So here's an example of that. Just to orient you guys again, this is the right coronary artery over here. Again, it should come all the way down here, right? So it stops right at the very beginning there. This person, you can see the sternal wires. This person already had a bypass graft. So bypass is good. Again, sometimes the bypass grafts close off. So this person already had a failed bypass graft. So it's coming back. Well, you decide, do you send them back for surgery again? The redo operations are a little bit higher. You've had scar tissue and adhesions. This is a pacemaker, if you've never seen a pacemaker. The 2 wires in the atrium and the ventricle. Okay, see a lot of things on x-ray there. Here's the spine here. So for this person, again, you really need to see the vessel beyond the occlusion. So we shoot the vessels from the left side going backwards, okay? And you can see the left side vessel here comes down and fills in again. A lot of this right coronary artery fills in backwards. So you're still getting blood supply there, not as much as you would with normal forward flow. Do a couple of different angles here. So the important thing to do is to identify what we call a septal collateral. The septal are the little branches here. I put the picture up here again to show you these little squiggly lines here. This is actually going right through the middle of the heart, right between the left and right ventricle, and it crosses over backwards into the right coronary artery. Those are called septal collaterals. So again, this person typically, if you really want to relieve his symptoms before these techniques, would have to undergo a second operation. And again, now you're probably a decade older and so on and so forth. So we identify this vessel here. You can see these vessels come all the way down, little squiggly lines here, goes down to the vessel and connects to the right side there. So what we've shown you here, now they have special wires and special techniques. Here's that catheter called the Corsair that's into the septal now. Again, it made a hairpin turn into that septal. And now I show this in real time, how quickly we can actually cross some of these septals. I don't know if you can appreciate it very well. See this little black tip here? That's the wire going from the left vessel to the right. I'll play again here to kind of follow along right here. See how it's going backwards now? So in literally, I don't know how many seconds that was, about 10 seconds we've crossed through the left side, and now we're going backwards in the coronary arteries. To about here, this person had 2 occlusions going forward, so it took a little bit more work. But now what you do is you pass that little fancy Corsair catheter I showed you. Now that's going to snake its way over the wire, and again, that's going backwards in the whole system now. You can see it making its way over here. Until you get to the point where you have the catheter right up to the occlusion on the other side. So you have the catheter to the occlusion on the forward side, a catheter and the occlusion on the distal side or the far side of that. And you basically pass your wires and get the 2 wires to connect. Now you can see here, we were successful. My colleague, Dr. Reginald Lowe, who's our chief of cardiology, the 2 of us do our CTO practice at Davis. He was working forward right here. He got his wire to here. I was working back this way. We got our 2 wires to kiss. This is called the kissing wire technique. So the 2 wires touch. Now we know we're in the true vessel beyond the blockage and the true vessel before the blockage. Now it just becomes relatively simple angioplasty. You pass the wire. It's called externalizing the wire. You actually pass the wire all the way through the left coronary entire system, backwards. You come out the other side, and your wire actually comes out the other leg. So now you have a whole wire going through the entire heart, coming out the other side. Almost like dental floss, right? Pretty crazy. It's pretty crazy. When I first heard this, I'm saying, we'll never do this here. But it's become a mainstay of what we do, and it's really made some of these cases really much more approachable. Then at that point in time, it just becomes, you turn your gear around and go backward, you go forward now off the backwards wire. And then it becomes angioplasty here. I didn't want to show you all these again. Small balloons first, bigger balloons to really expand. Sometimes you need the laser, sometimes you need the other types of equipment to open up and prepare the lesion. And then you end up putting, again, these long blockages require multiple stents. So here's a stent going down here, another stent here, another stent here, and 4 stents. So we call that a full metal jacket. So we got 4 stents, and here's what the final angiogram looks like here. Pretty amazing, right? So again, this is someone who, no question, would have had to go undergo a second operation. Again, 2 holes in the legs, went home in 1 day. So approaching chronic total occlusions, not that easy. Occasionally you get into trouble. You have to get yourself dug out of a little trough here, out of a ditch here, get someone to help take you out of there. But despite doing all the things perfectly, the proper technique, preparing for the lesion, you still don't guarantee success. Not good, right? So despite our best intentions, we still get into trouble. So then you know, we have improved techniques here. I changed a little label here. You call your friendly neighborhood cardiologist, call Dr. Lowe, give someone to give you a hand. Better techniques, better technologies, more complex interventions now. Getting really hairy there. But still, sometimes despite our best efforts, there's still no guarantees. So in the last few minutes here, I want to switch gears a little bit and talk about what to do once you get the vessel open. I've talked about the stent a little bit earlier, but really once you open the vessel, you have to put a drug-eluting stent in here. What this slide shows you is I didn't say on the y-axis, but this is the restenosis, the amount of time you have to come back to be retreated. So with a BMS or uncoated bare metal stent, a third of these people had to come back in to be retreated for scar tissue. So you can see all the yellow. These are numerous trials that have been done over the years with this drug-eluting stents, and you really need that drug coating to prevent that scar tissue, especially if you put 4 long stents in there, right? The more metal you have, the higher chance you can have scar tissue. So the first generation stents were great. These are the 2 I talked about with the sirolimus and the paclitaxel. They have this fancy coating on them with the polymer. This is looking on a scanning electron microscope. You can actually see the durable polymer on the vessel, on the stent. And there are different types of stents. So these evolved into multiple different stent patterns that give you radial strength and tortuosity support and so on and so forth. So these have come a long way. And in fact, the very first stents when it came out was a sirolimus trial here, and it shows you the lesion here. Right immediately after, it looks great, nice angiographically good view. The problem is with the uncoated stents, a quarter of the time you had to come back in with that scar tissue. With this person, if you follow that same exact person 7 years out, looks great. Okay, now this is a very simple lesion, doesn't involve branch points, it's not a CTO that we talk about, so those are the ones that give you great results. But comparing, so all these stents, all the drug-coated stents, they had the uncoated stent first that got proven to be safe and effective. Then they had the drug coating on top of that. So all the early trials compared the uncoated stent here. So you see on the blue, the bare metal stent here versus the yellow, the drug-coated brother of it here, so to speak. And on the y-axis here is something called TLR, target lesion revascularization. It means that someone clinically had symptoms or signs that had to come back to be retreated. They had another heart attack, they had positive stress tests, and so on. So you can clearly see a marked reduction in the need for repeat revascularization with these newer drug coatings. Now these are first generation stents, and again, here's that same patient at 7 years doing great. If you look at there's a lot of busy slide, I'll kind of walk you through it. So focus right here. This is the actual blood vessel from animal models. If you cut open the vessel in lengthwise here of a person who had an uncoated stent, you don't see the stent at all. It's covered by a layer of tissue, a so-called layer of scar tissue. Now, sometimes, again, that scar tissue is too much, you have to be retreated. So the drug-coated stent is right here. So you get a little bit of that drug coat, a little bit of the stent covered by the tissue, but sometimes, unfortunately, because of that drug on there, you don't completely cover the stent with a layer of blood vessel lining, what we call endothelium. So you think that'd be good, right? The problem is, if you look actually with a camera into the blood vessel called angioscopy, you can see the shiny metal here, that's uncoated metal. Uncoated metal that's not covered by a protected layer of tissue can be very clot forming. And what happens is you get something called stent thrombosis. It's a new process. We talked about stent restenosis, the slow growth of the scar tissue. Thrombosis is when it completely shuts off like that. You form a big clot, just like a heart attack, because you have the metal that's uncovered. Okay? So that's what happens. They come back in for an acute heart attack. We get the 911. We rush them to the cath lab and have to start all over again. Also having the piece of metal in there, you talk about the vasomotor function of the vessel. Normally the arteries are able to expand and relax and so on. We want that vasomotor reactivity of your blood vessels. Putting a big piece of metal in there obviously doesn't allow that to occur anymore, right? It's a rigid tube inside that vessel. Now it does become a pipe. Talking about stent thrombosis, the early generation stents, unfortunately, they do have about a 1% per year risk of forming this clot inside the vessel. And what does that present as? Heart attack. They don't come in with little symptoms. They come in 911 emergency. So up to 5 years, 1 to 2% per year of these people had to come in emergently for treatment for that stent thrombosis. Even when this data was first coming out, it made the national news, New York Times, Wall Street Journal, well, these drug-eluting stents even safe, or the increasing death. Subsequent to that, it's been shown that the numbers are exactly in line with their bare metal, the uncoated counterparts. So bare metal stents aren't perfect as well, but certainly they've been our mainstay. So we move to the second generation, and well, can we get some improvements on there? Improvements are the new coatings here. They have a better form of sirolimus. It's a different type of drug coating here. Everolimus has a new polymer, which is much more biocompatible. It's not as inflammatory. And now the stents have gotten better as well. Instead of surgical stainless steel, we've come to different alloys. This one's made of a platinum chromium alloy. This is a cobalt chromium alloy. So that you can go thinner and thinner metal, but still get the same strength when you combine different metals properties. So you want a very thin piece of metal, so so it gets covered by a layer of protective tissue a lot earlier. And again, don't want to show you too much data here, but comparing the first-generation stents versus the second-generation stents, again, the need for repeat revascularization is markedly reduced with the second-generation stents. So that's currently the standard of care right now. What about stent thrombosis, the people that clot off the stent? Again, marked reduction. It's down to about less than 1% after 2 years, so about 0.5% per year on average now of a stent closing off acutely causing a heart attack. So it brings us to the principle, well, do you want this so-called caged vessel? You put the metal in there, patients ask, can I ever take it out? No. You get a stent there, that's with you. You take it all the way. So you take it to heaven. So here's your stent here, and those different things can happen. So this is the best course of action you want to see right here. You get a little layer of protective tissue. You completely cover the stent, so it's not as likely to form a clot. And they do fine. They do great. No good blood flow. Some of the stent does this. It doesn't get completely covered by a layer of tissue, so you always have that metal exposed, and again, can lead to acute clot forming off of that stent there. What could also happen is getting too much vessel tissue growth inside there, and that's the in-stent restenosis I talked about, and you have to come back in and get retreated for symptoms. Also, what can happen, the vessels are very dynamic, and the vessels can actually grow over time, and the vessel wall actually grows away from your stent. So now you have this metal floating in the wind, so to speak, and again, it's going to never get covered by a layer of protective tissue, right? So again, the top and bottom examples could lead to the so-called stent thrombosis, 911 emergency. Well, what if you could put a stent to that would give you the properties, prevent that immediate elastic recoil, but over time, disappear? That'd be ideal, right? It'd be pretty amazing you can do that because it would keep the vessel open and does not allow that elastic recoil. When you don't need it, after about a year, it would be gone. That'd be ideal, right? Just having the metal alone leads to more of the cell growth just because it's very inflammatory. If you get rid of that metal, the tissue growth stops and you have a nice big lumen here. So that'd be ideal because you really don't need a vessel stented for that long period of time. It's really only needed transiently, it's first 6 months, maybe a year. So it'd be great if we had that, right? Somewhat off in the future. Well, the future is now. We actually have this technology right now. Pretty amazing. So there's many companies doing this on the market. This is the first one to be commercially approved. It's approved in Europe. It's not available here yet. We're doing clinical trials on this here. We actually are part of this at UC Davis. We put in about 6 or 7 of these so far. And it's made out of this material called PLA, or polylactic acid. Don't want to go through too much of the components here, but polylactic acid is a natural occurring material that over time just becomes hydrolyzed into carbon dioxide and water. You dissolve it away by your body's own natural metabolism. So both the stent is made out of PLA, the stent coating, where you can embed your drug into there, is made out of absorbable PLA, and use the same exact state-of-the-art drug and the delivery system that we've used for the current generation drug-eluting stents. Not going to go too much into the biochemistry, but basically lactate or lactic acid gets put into the whole Krebs cycle. Your body uses it for anaerobic energy source, and you basically break it down. Remember this Krebs cycle back in our biochemistry days? I'm sure there's some biochemists in the room here. And basically break it down into water, CO2, and energy. And for the true biochemists in the field, I put this here. Certainly won't go through this with you guys here, but basically you spin through this Krebs cycle here and you come out with carbon dioxide and water and dissolves away. What does that look like? There's something called OCT, optical coherence tomography. We actually use a light source now, and you take high-res pictures inside the blood vessel wall. And so this is actually looking inside the blood vessel wall. You can see when the stent first goes in there, you see this kind of corrugated appearance. That's a stent. The tissue kind of prolapsing through that a little bit. At about 6 months, the stent starts dissolving away, and you start seeing little breaks in the stent here. 1 year, and certainly 2 years later, the stent is completely gone. Nice, smooth surface. Whether you've pinched off a side branch, whatnot, it's gone. So this is certainly what we want to do. It keeps it in place for about 6 months to prevent that immediate elastic recoil. There are numerous publications, well over 100 publications on this one particular stent. This is the first one commercially to market. There's many studies. It is now commercially approved in Europe. They've been doing it for about a year. It's almost become their standard of care over in Europe. Here's where we are in the US. We're right here, the US randomized clinical trial. So the plan to enroll 5,000. They're almost done, actually. I think they need 600 more patients. So literally in the next couple months, we'll be done with this. We'll follow these patients up for X amount of time, and hopefully this will be approved probably by 2015. So this brings us to this, what we call the fourth revolution. As I showed you from the early pictures, Julio Palmaz and Richard Schatz came up with the first balloon angioplasty in 77. 14 years later, the eras of stents really came about and really made stenting a lot easier, more approachable, more safe for everybody. Drug-coated stents really minimized the need to go back for repeat operations and allowed us to do much more complex lesions. These chronic blockages that had to go to a surgery before now could be treated with good, durable results. And now, fourth generation is coming very soon. It's been approved in Europe. They're getting great results with it. So now you could put these stents in there but not commit this person to a full metal jacket like we did to the other patient. Here's some of our team here. So that's like one last summary slide here. I appreciate your attention here. But so just to let you know, there have been significant advances in the field of interventional cardiology, and previous patients who have been seen as bypass surgery-only patients can now be successfully treated with PCI and stenting. The stents are dramatically improved, even since my short time in cardiology. And some of these BVS or bioabsorbable stents are certainly improving. Ongoing studies are certainly needed, but the trials are coming, and it's technology that's here to stay. So I appreciate your time. Thank you very much.